save a person's life who has an accident trauma. Hello everyone. First, we need to know what is trauma. Trauma is a life-threatening event or series of events which can be emotional or physical. Imagine you're walking across the street and suddenly an accident occurs in front of you. So, what would you do? Definitely at first you call 911, but here we are to tell you what to do before calling the ambulance. The most commonly used approach for trauma is ABC. A is for the airway, B for breathing, and C for circulation. In order to check the airway, you should ask the patient if he can speak or not. Normal voice and speech indicates a patent airway. Any abnormal voice such as stereo, hoarseness, or pain while speaking can indicate the obstruction of the airway or any problem in the airway that could be checked. In the obstructed patients, the tongue can partially or completely obstruct the glottis, and this can be one of the factors that obstruct the airway too. Complex facial fractures and tissue disruption above the nipple and seeing blood in the mouth or airway can obstruct the airway and needs an intervention. So let's see what can we do when an obstruction happens. Tipping the chin upward, which is called chin lift, or pulling the mandible anteriorly, jaw thrust, while maintaining spine immobilization are two simple maneuvers that may reopen the airway and assure oxygenation and ventilation. So with one hand on the patient's forehead, two fingers underneath the patient's chin, I'm going to push down with my left hand and keep the chin raised with the two fingers of my right hand. You can also see in this position on this model how it affects the bones of the neck. And that's why we wouldn't use this for someone who we had concerns about a C-spine injury. The other airway maneuver that we could consider is the jaw thrust. So I'm going to put two fingers on each side of the mandible, underneath the angle of the mandible, thumb on the cheeks, and in this position I can lift the mandible forward to help bring the tongue forward and stop obstructing the airway. Nasopharyngeal devices are better tolerated in the conscious patient but should not be used in the presence of mid-face injuries. The most definitive way to secure the airway is with endotracheal intubation. This procedure requires skill and experience and involves passing a tube with an inflatable cuff through the mouth and vocal cords into the trachea. If the glottis cannot be intubated via the oral route, a surgical airway must be performed. This can be achieved by placing a cricothyroidotomy or large bore needle. This figure here illustrates the incision used for an open cricothyroidotomy. Once the cricothyroid membrane is opened, a 6 French or smaller endotracheal tube is placed directly into the trachea. The needle cricothyroidotomy is quicker to perform than the open approach. A large bore, which is 16 to 18 intravenous catheter, is passed directly through the cricothyroid membrane. The next thing we're going to discuss about is breathing. Breathing is assessed by inspecting the chest for symmetric movement and auscultating for breathed sounds. Cyanosis and poor oxygen saturation, despite the presence of an airway, may indicate poor ventilation. Attention pneumothorax results from a lung injury. Air from the lung enters the pleural space and the intrapleural pressure increases with each respiration. As the pressure rises, the mediastinal structures shift to the contralateral side and impede venous blood return to the heart. So this results in a decrease in cardiac output and shock. The diagnosis of attention pneumothorax is made on physical examination. The triad of absent breath sounds, shock, and muffled heart sounds confirm the diagnosis. Immediate treatment is directed at decompressing the intrapleural hypertension. This is accomplished by either placing a large bore angiocath into the second intercostal space at the mid-clavicular line or inserting a chest tube at the anterior axillary line. And the next part is circulation. The evaluation of the circulation focuses on prompt recognition and reversal of shock. So shock is defined when we have an adequate tissue perfusion resulting in anaerobic metabolism, and prolonged tissue hypoxia causes organ dysfunction, irreversible tissue damage, and eventually death. Tachycardia, tachypnea, hypotension, mental status change, agitation, anxiety, oliguria are common signs and symptoms of shock. Additional signs include cool, clammy, or cyanotic skin and diminished peripheral pulses. Although most external bleeding from traumatic wounds can be tolerated temporarily with direct pressure or a tourniquet, intrathoracic or intra-abdominal hemorrhage may require more invasive measures, such as a tube thoracostomy, surgical intervention, or angiography with embolization. In emergency situations where blood pressure cuff is not available, we can roughly estimate the systolic blood pressure by checking which pulse is palpable. When carotid pulse palpable, the SBP or systolic blood pressure is over 60. When femoral pulse palpable, the SBP is over 70. And when radial pulse palpable, the SBP is over 80. This method is especially useful in trauma or shock patients to quickly assess the circulatory status. If no pulses are palpable, it usually indicates a systolic pressure below 50 to 60, which is a life-threatening condition requiring immediate intervention.